Hi everyone, my name is Shen Lamson. I'm the doctoral student from the Factory in Vantage Faculty of Social Work, University of Toronto. As a social work professional and also a gerontologist in training, I always have a question that whether the refugee came to Canada, whether they age well in our society, and what happened after they migrate to our country. So this is with this question, I start my research, and this is the topic presented today: the depression among middle-aged and older Canadian refugees in the Canadian Longitudinal Study on Aging. And we found that social support play a fundamental role. First of all, I need to acknowledge, and this is a disclaimer, that the co-author of our research teams, and I'd also really appreciate that the annual student and trainee abstract award that I got for this conference, and I made my presentation happen today. So I will briefly talk about some mechanism about the social determinants of refugee mental health. So as shown in this diagram, before migration, during migration, and after migration, refugees actually suffer from a lot of trauma. And for those pre-migration trauma, they will have like exposure to war, persecution. During migration, they may have like human trafficking and separation from their family members. After migration, in the host countries, they may suffer from discrimination and reduced social network, etc. So all this kind of like stressors experienced by the refugees, actually, this kind of disparities actually contribute to the disparities in mental health outcomes between refugees, immigrants, compared to Canadian-born individuals. So our study today is an empirical study that would examine these three research questions. We particularly look at, for both refugees and non-refugee immigrants, whether they have a higher prevalence and adjusted of depression than native Canadian-born Canadians. And also whether there are any other attenuating factors that could attenuate the association between refugees, immigrant status, and depression. And the last question is whether there's any other social determinants. And this kind of questions could actually inform the refugee policy planning and also appropriate mental health care. So the data we use is from the Canadian Longitudinal Study on Aging. Is actually we're using the baseline comprehensive cohort, which has 30,000 Canadian aged 45 to 85 years old, and they will be followed up for 20 years. We restricted to 29,000 people that, for those who with missing value will be were excluded. And this is the data analysis plan and also our statistic model. We look at the bivariate analysis, comparing the means and the percentage, and also we use binary logistic regression to look at the depression outcome. So we also control for the demographic variables. The focus, of course, is the refugee and immigrant status, and then we also control for socioeconomic status, that is income, education, retirement status. We also control for drinking, physical activities, multi-mobilities. And we have also constructed a variable and measure on social isolation. So this is our key measure of operationalization. For social isolation, we look at, we categorize it into three levels, whether it's isolated, mildly isolated, and extremely isolated. And then it will measure outside the household whether it had face-to-face contact with family members, friends, and neighborhood outside the household. For the level two, we look at whether they live alone or not live alone. So we actually have 6 categories. And then we also look at online social networking, whether the participant actively use social medias to stay in touch with their family and friends. And last but not least is the social support. We look at 3 major indicators. One is whether they have someone that give advice about a crisis, and whether they have a confidant, and whether there's someone who show love and affection. So this is the profile of the refugee identified in the CLSA baseline. And we actually found, this is actually a variable that constructed by country of birth, year of arrival, cultural and parental and ethnic backgrounds. And we found 272 refugees in our sample. So for the bivariate analysis, we found that actually refugees have lower social support and actually higher social isolation. 27 point, actually a quarter refugees have actually no one, have no confidant, and a quarter refugee also actually no one give them advice about a crisis. And also out of 6 refugee, they don't have someone to love them. For social isolation, we could also find here refugee actually have higher percentage than native and non-refugee immigrant and Canadian-born residents, that they are actually very isolated or mildly isolated. And then when we look at their depression result, we also found that refugees and also non-refugee immigrants have higher depression prevalence compared to native-born Canadians. So we found that 22% of refugees have depression compared to 15% of Canadians have depression in the data set. And when we look at the multivariate analysis controlling for all the other variables, we found something interesting, that when we adjusted for socioeconomic status, health behaviors, social connections, social isolations, these variable actually, the depression for refugee is significant. That means they are really have higher prevalence than Canadian-born residents. But when we adjust for social support, you will found here the blue statistic indicate that the odd ratio is not significant anymore. So you will see in the final model when we adjust for social support and in the complete model that have social support there, the odd ratio for refugees across 1, meaning it's not significant. So this finding suggests that the powerful effect of social support, that it could actually attenuate this association between refugee status and depression. But this patterns is not observed in the non-refugee immigrants. So they are all above 1, meaning they are all significant. We also found the other significant social determinants that related to depression. So this kind of risk factors, including younger and also you are single, lower income, lower education, they also have more than 1 odd ratio, meaning have higher, more likely to be depressed. And also if they have more health conditions or less social support, they will be more likely to be depressed for sure. And we also find that social support attenuate the association between social isolation and online social networking with depression. So this is our implication. First of all, we found that this kind of 3-item social support factors representing close relation have huge health impact. This 3 important social support indicator is having someone who loves them, having a confidant, having an advisor in case of a crisis. But what's unfortunately is that when we are in our bivariate analysis, we found a quarter of refugees don't have this kind of resources, or one out of 6 refugees don't have advisors in case of crisis. And refugees actually are more prone to emotional isolation. This may be attributable to the geographical distance from their family members, or actually because of their pre-displacement exposure to human rights violation. And this will lead to actually their disruption in ability to trust and interact with others. And ultimately, it will affect their long-term, it will create a long-term psychosocial difficulties in forming close relation. So our implication for healthcare practice, actually mentioned by Dr. Azar, the first panelist before, we need to develop early group-based mental health intervention because we know that human connection is very important for refugees, and the social support representing those close relations. Actually, we need to develop nurturing those supportive interpersonal relationships between our refugees. And also, we found that actually the quality of relations rather than the quantity of association measured by the social isolation matters. So the social support attenuate the association between social isolation and depression, meaning the quality of relationship really matters to their mental health well-being. And the implication for the refugee policy is that in Canada, in the Canadian context, we have the privately sponsored refugees and also government-assisted refugee program. And there are results show that actually private sponsored refugees are more likely to thrive post-migration because they got more social support from those private sponsors and volunteers, that they get higher employment rate and fewer unmet needs in their resettlement process and integration period. So, and also this is our limitation for our study. It's a cross-sectional data and it's self-reported data, so it may create some bias and also secondary data analysis. For future direction, we will look at some longitudinal subgroup analysis comparing the private sponsored refugee and also government-assisted refugee on their mental health outcomes. Thank you very much. I would like to take some questions.
Any questions?
Yes, I'm very pleased to see that there is more research being done in this area. I work for the Canadian Centre for Victims of Torture, and it is a pleasure to see that this is endorsing a lot of the work that is being done in the community, not only by our centers, but by many other organizations. Group work for refugees is paramount. So are you publishing your presentation soon?
Public, you mean?
Are you going to publish it?
Yeah, it's going to be published by the Journal of Immigrant and Minority Health. Yeah. So
okay, I'll see you after, because it's often very important for community agencies to back up applications for funding with new research, not with old research. That document the same anyways, but it's new, it's fresh, and it's good to have it. Thank you very much.
Thank you.
Thank you for your exciting research. I may have missed this, so I apologize if it's already been discussed, but can you tell us a little bit about how you documented or defined depression in this study?
Oh, sure. I missed that point. Actually, the depression, we used a derived variable that this Canadian longitudinal study, they actually study on aging. They have this kind of a very common scales that is their Center for Epidemiological Study short scales, and we use the cutoff 10 out of 30 that would screen as positive for depression.
Like was it a defined? Sorry, is this something that you can use in your office, or was this a set of questions that was developed?
It's the scales that we've actually 10 variables with 10 items, and then you can screen the participant or your client whether they are depressed or not. It's actually a screening tool, but not a diagnostics tool.
Okay, thanks so much.
Great. Just in keeping with time, we'll let Ms. Thompson.
Thank you.
Which he and his team looked at this data set with around 30,000 Canadians in it, and really were able to concretely identify the issue of social support as a risk factor for depression among older refugees at much higher rates than we're seeing in non-refugee immigrants as well as native-born Canadians. So complicated statistical analysis that he did on his own, and an excellent manuscript and abstract. So we're going to congratulate our winner, Lamson.